Hello, this is your brain on drugs, and this is the punk rock psychiatrist. And we've been talking about stimulants for ADHD, and it's time to talk about non-stimulants. So this is another way to treat them. I'm going to have two episodes on non-stimulants because there are quite a lot of options, though most of them are off-label. Today, I will give you an introduction to non-stimulants, when to use them, why to use them, what are all the options, and then we will talk about the first two medications that we're going to talk about, non-stimulants, and then on the part two episode next time on ADHD, we will talk about the other non-stimulants. So why even consider these non-stimulants? I mean, they don't work as well as the stimulants. The stimulants saying, your methylphenidate, your amphetamine, like those medications are incredible. They're like the best medications that we have in psychiatry to treat any condition that we have. I love using them. I personally, I'm struggling to remember when I actually used non-stimulants. And like I said, I treat adults, and in my population of adults that I treat, I pretty much never find a use for non-stimulants. If I were seeing a lot more patients than I see, and I were seeing tons and tons of ADHD, and I were seeing kids, I would probably use these more often. Um, I have used them. I don't know if I've started. I may not have started that many, um, but they're just not as good as the stimulants. And so, what are some reasons why we might use these? Because they are frequently used. All right, we'll talk about that too. So the stimulants are Schedule 2 drugs. So there is some abuse liability, but we've talked about how it's not nearly as high as people think it is. There's risk of diversion, which does happen, right? So that's, giving it to other people or being stolen or using it for reasons you're not supposed to. There are um, a couple of stimulants though that we have less of a concern. So like the Lisdex amphetamine Vyvanse or the Surdex methylphenidate, the Astaris, the newer one, we have less risk of that. So there are ways to use stimulants if these are concerns. Um, 10 to 20% of folks do not adequately respond to a stimulant, or they don't tolerate the adverse effects that they're getting from them. And so these are folks that I think you could probably fine tune, find the right stimulant, find the right dose, find the right timing. I think in my experience, 10 to 20% sounds a bit high. That's what I've read. This is not from personal experience. In adults, at least, I don't find this many that have. In fact, I'm struggling to think of adults that I have not found that have not done well with stimulants, but they're out there, and with kids, perhaps a bit more issue there. So there may be just folks that the stimulants just don't work for whatever reason. So we have other options. You might be thinking, well, if those don't work, something that's less effective is even less likely to work. Well, that's not necessarily the case. So this might be exactly what their brain is looking for. So nice to have it available to use. The stimulants have a shorter duration of action, perhaps, because if they take them like around the clock, they're not going to be able to sleep. With the non-stimulants, you don't have that issue. And so if they do work, they're going to work while they're awake all the time instead of just for that. Like in some cases, folks only get used for 4 or 5 hours, especially in the adult population. And so as we struggle to have that work longer without affecting sleep, that can be an issue with the stimulants. And so with the non-stimulants, less so. Also, the side effect profile with this, I mentioned the sleep, but also appetite, mood, anxiety may be negatively affected with the stimulants. And so this is an alternative. We have the concerns about growth suppression, but as I've talked about before, that really doesn't pan out long term. But the thing is, we're talking about averages. There are people that it is going to be an issue for. On average, it's not, but there will, this is why we have to personalize care. It may be one in not that many out of that, not that many patients that are affected by a certain issue that I say, oh, substance abuse is really overblown, or growth suppression really overblown. There are patients where that actually is a really big concern. So that would be a time to consider non-stimulants. Tick development, some people get ticks from the stimulants. So that this would be an alternative for that. So basically, if a stimulant's not working, or if there's abuse potential, or if there's adverse effects that we just can't get around, these are times when we would consider non-stimulants. And so let's go through all of the options here. And so we've got some categories. Today we're going to talk about the selective norepinephrine reuptake inhibitors, the SNRIs, really the NRIs, because SNRI is serotonin norepinephrine, so selective norepinephrine. So we call SSRI is selective serotonin reuptake inhibitor, but we don't say these are SNRIs because that would be confused with serotonin and norepinephrine reuptake inhibitors. So these are NRIs, norepinephrine reuptake inhibitors, but selective. It is selective for norepinephrine. So that works similarly. We're blocking the reuptake pump so that more norepinephrine in between the terminals there. Of course, the stimulants are NDRIs, norepinephrine dopamine reuptake inhibitors. In addition to they work a little bit differently. These just increase norepinephrine, and the two medications that we have are atomoxetine, otherwise known as Strattera, which came out in 2002, and the newer kid on the block, Viloxazine or Qelbree, which came out in 2021. The next category of non-stimulants, we have the alpha adrenergic agonist. These are alpha 2 agonists. We've got clonidine. So we've got basically clonidine and guanfacine, and then we've got different options for each. So clonidine binds to alpha 2A and 2C more equally, whereas guanfacine is more selective for 2A. I'm not sure necessarily what impact that has. So 2A and 2C are they're like subcategories of alpha 2. I've tried to figure out what's the difference between 2A and 2B, 2C, 2D, or whatever, and it's hard to kind of figure out what that is. I'm not sure if there's much of a difference or if we know. In the clonidine category, we've got an IR known as Catapress, which is a really old med from 1966. This is off-label, so this is not FDA approved for ADHD. The branded product known as Catapress has been discontinued, and you have to take it multiple times a day because it's an IR. We've got XR. We've got two XRs, Qelbree, which came out in 2010, and the newest one, this is the very newest one, Oneida XR, came out in 2024. We'll go into detail on these later. And then we've got guanfacine. We've got the IR version, which is 10x, and the XR version, which is Intuniv. 10x is off-label. Intuniv is FDA approved. Qelbree and Oneida also approved. And then we've got some antidepressants, the tricyclics. So imipramine and desipramine are ones that used to be used a long time ago, and you can kind of see where that makes sense because these are those are more norepinephrine selective tricyclics, so they're similar to atomoxetine and viloxazine, the ones we're going to talk about today. But they're dirtier because they affect cholinergic and alpha and histamine and other receptors, so they're not super selective for norepinephrine. We have better options in Strattera and Qelbree now. So those are off-label. They used to be used. I never seen them used in my career. Just kind of historically, they were used. And then we've got NDRIs. So like our stimulants, our actual stimulants, methylphenidate and amphetamine, we have other NDRIs. We've got bupropion, Wellbutrin. Doesn't work that great, but it can help, especially if you're treating a comorbid condition for which bupropion would be helpful with, like depression, anxiety, tobacco cessation, etc. It's off-label. And then there's a newer one, solriamfetol. The brand name is Sanofi. This is a medication used for narcolepsy. It's off label for ADHD, but it is an NDRI. Might it get approval at some point? Maybe. I think it's being studied for some things, some other for some mental health conditions. But currently, its only approval is for narcolepsy. And then lastly, we've got saffron, which is an herb essentially. It's the male reproductive organ known as the stamen of the flower, and it's actually known as the most expensive by weight spice in the world. It's not really a spice; it's more of an herb because it's a plant part. Um, I think of it more as an herb, but perhaps spice, herb, whatever. And we'll talk a little bit about saffron as well. That would be more of an alternative treatment, a non-medication treatment. So that's the list of non-stimulants, both on label and off label for ADHD. And so today we're going to talk about atomoxetine and viloxazine. So, as I mentioned, selective norepinephrine reuptake inhibitors. I'm going to go through some generic information that kind of applies to both. And then we're going to talk about each medication individually. All right. So, um, they increase not just norepinephrine but also dopamine, because blocking the norepinephrine reuptake pump also has effects on increasing dopamine, though not as much as one that would block dopamine's reuptake. Um, it's not known to, so it increases norepinephrine and dopamine in the prefrontal cortex, but it doesn't increase dopamine in the pleasure center. And so we're getting some dopamine, but mostly norepinephrine effect. But we're not having that addiction abuse potential because it does not increase the dopamine in the pleasure center as the stimulants do. So that's how it would work for ADHD, but perhaps have a different side effect profile. All right. It is FDA. These medications are FDA approved for ADHD in children and adults 6 years and older. And there's a what I feel like is a ridiculous black box warning. You know how we have these black box warnings on the SSRIs for suicidality? We've talked about that in depth. I have an entire episode on that. So if you're interested, go check that episode out. That was a long time ago. Um, for some reason, they decided to put apply this same black box warning to atomoxetine and viloxazine back in 2005. Um, there were some kind of smaller studies that showed that there was an increase over placebo for atomoxetine, but much larger subsequent studies have shown absolutely like no correlation. And even when that was seen, it was only in children and not in adults. So if like you were using this for adults, there's really, the risk is negligible. It's like same as placebo. Um, and then, or I would say like nocebo, because this is a bad effect. But um, even subsequent effects on kids have kind of shown not been able to replicate that. Yet the black box warning remains. And so the small increased risk that exists with the antidepressants, um, which does occur, actually is probably not even a thing at all with these medications. So that black box warning is on there. It's probably going to scare some people into not wanting to prescribe it. It's something to keep in the back of your mind, but it should not influence your like choice to use this. It's just more like, hey, be aware that this could happen. If you see it, kind of beware that like, oh wait, maybe that's because of this medication. But like the risk is really, really quite small, if there at all, to be honest. All right. These meds are dosed differently. Atomoxetine is weight based and viloxazine is age based. I will go into detail about that when we talk about the meds individually. So just kind of note that they are dosed in completely different ways. They're both metabolized by the liver. So by the 2D6 pathway, you have to be careful with atomoxetine is very sensitive to 2D6. It can actually increase tenfold if used in folks that are poor metabolizers of 2D6 or with 2D6 inhibitors. So that its levels can be increased quite a lot. It's very sensitive. Bupropion, or is it not bupropion? Sorry, buspirone is another one that is really sensitive. It's like a ninefold increase. So this is like even more than that. However, the main effects are going to be fatigue, somnolence when you have this interaction. So it's not like it's a life threatening interaction, but it could make it to where the patient doesn't want to take the medication, right? So you could consider genomic testing, looking for poor metabolizers, um, but I tend not to waste money and time with that, and just kind of like cautiously use the medication. And if I notice something funky going on, might be like, hey, maybe you're a poor metabolizer. We should give you a lower dose or a different med. Um, the effect size, we talked about the effect size with the stimulants being quite high, like 0.9 to 1 range, which is like massive. Um, it's less with these, but still pretty good. I mean, when we're talking about antidepressants, we're looking at like 0.3. And with atomoxetine in children, 0.7. So not as good as stimulants, but still actually pretty darn good. 0.44 with adolescents and adults, less good, but still not bad. But of course, I would rather use something that's better if I can get away with it, right? And then Viloxazine effect size around zero point 0.6. I don't really have information on the difference between kids and adults. I mean, pretty big difference between kids and adults. So atomoxetine, pretty good effect size with kids, pretty meager effect size with adolescents and adults. And like, that's the majority of like, most of your patients are probably going to be adolescents or adults anyway. And you're going to be kids that are going to turn into adolescents. So what is this going to get less effective over time? Something to keep in the back of your mind. And then, of course, being that these affect the alpha receptor, they can affect our blood pressure and heart rate. So you definitely want to keep an eye on those. EKG, not something that you should have to deal with, but if there's some sort of clinical concern there, um, you might want to check it, but it's not certainly not mandatory for everyone. But blood pressure and heart rate are things that you definitely want to keep an eye on, and you should be pretty much all the time anyway. So next, we're going to talk about atomoxetine specifically. All right, so atomoxetine, it's been out for a while, 2002, brand name Strattera. You could use it first line. So these are the patients that like we would use it in. Typically, this is going to be third line. All right, like I'm going to go with typically I'm going to go with amphetamine first, and then I'm going to go with methylphenidate second, and then I'm probably going to, like, depending on how they react, their side effects, I might try a different amphetamine or a different methylphenidate. But like, I'm going to use those two category of meds first, and this is typically going to be my third line treatment if if I'm having tolerance issues or it's not working. But you could consider it earlier on in some situations. If the patient or household member has a history of substance abuse, it could be a consideration, though I'd probably go with something like lisdexamfetamine before I would do that. But this is another option. Um, if the patients have tics that are happening because of stimulants, and remember, you can get tics from ADHD as well. So like, you have to, they're very comorbid conditions. You have to, so, but if the tics are tied to the stimulant, these can actually help with tics. So that would be, if that's an issue, you might want to try a switch to atomoxetine. Um, Now, remember, these are NRIs, so like that's similar. Many of the antidepressants are NRIs, but SSRIs or SNRIs or NRIs. So these can actually help with your anxiety or depression even. Um, though I find the stimulants can also do that. Now, the difference between the stimulants and these non-stimulants is, remember, the stimulants are very short acting. So you're probably not going to want to use an amphetamine as like a primary treatment for depression, anxiety with ADHD, because it's just not going to be working 24/7. And that's, for ADHD, we don't necessarily need it working 24/7, but for depression, anxiety, we do. Now, if you're taking an antidepressant and then you maybe add an amphetamine or methylphenidate on top of that, is like an adjunctive treatment to help with anxiety and depression and energy, focus, etc., symptoms of depression, but maybe not with ADHD, but with some ADHD kind of characteristics. That would be something I would use the stimulants for. But you could even consider a medication like atomoxetine to treat depression, anxiety, and ADHD as the only medication because it does work 24/7. So that's another consideration to have. Um, and then remember, if we have severe side effects to stimulants, um, and the thing is, these side effects could also happen from the non-stimulants. So if you're getting like mood changes, you're getting weight loss, you're getting blood pressure issues, agitation, psychosis from the stimulants, you could consider the non-stimulants. That's not to say that you couldn't get, blood pressure issues or mood changes, etc., from these as well. But it's a different medication. They may tolerate it better. Okay. Um, Another big difference between these non-stimulants and the stimulants are the stimulants work like immediately. Once you have the right dose of a stimulant, it will, remember, it's short acting. So like it works and then it stops. It's not like the SSRIs and things that we talked about a long time ago with depression that, they take weeks to work. These are similar to that because remember, this is an NRI. This takes time to build up in the system. It takes time for your receptors in your brain to get used to it. Go back and listen to when I talked about like how pharmacologically like the brain adapts to SSRIs and NRIs if you want more details on that. But just kind of remember that these work kind of similarly to the SSRIs, and so they take a while to work. Not as long, not the 4 to 6 weeks, closer to maybe 2 weeks, but you're not going to see that immediate effect as you do with the stimulants. I love the stimulants because they work so quickly. These do take a bit longer. And also, they could even, you may not see an effect for a couple of weeks, but you may not see the max effect for a couple of months. So just because someone comes back and they're like, hey, I think it's working a little bit, but I don't know, it's like, well, you may not be at its max effect yet. Maybe the next month I see you, I don't need to adjust the dose, but we see how it goes after another month, we're seeing even better effect. So keep that in your mind, that on that first follow-up appointment you may not be getting the max benefit that they're going to get. Whereas with a stimulant med, you could see them a week later and we know what it's going to do and we can make an adjustment. Now, another big thing with atomoxetine in particular is you can't split it, crush it, sprinkle it, whatever, right? Remember, we talked about all the stimulants where many of them you can, and you can typically find a version of the drug you're dealing with that is splittable or sprinkleable. So for folks that can't swallow pills, right? Now, with this one, we do not have that option. You cannot sprinkle it. And another thing kind of to be considered is this can irritate your eye if it gets in there. So if it were to get in a powdered form and you were to somehow get this in your eye, it can like really bother your eye. So you would want to get that out. And someone might be like, oh my gosh, this is what I got this in my eye. And it's like really a problem. So that is a known issue with this. Um, we talked about drug holidays with the stimulants where it's like, hey, if it's losing its effect a little bit, take a few days off, maybe it'll work better when I come back on it. Or maybe I'm getting some effects I don't really like, but I don't need the effect of it all the time, so I might take some days off here and there. Maybe I take the summer off if I'm worried about growth or suppression or whatever like that. Not an option with these. You that this is a benefit of the stimulants. They work immediately, and they work when you take them. They don't work when you don't. And you would think that's how all meds work, right? No, these work like the SSRIs. You have to take them every day for them to work, and if you miss days, they're not going to work as well. All right, so just think they work kind of in the same way as those. Stimulants are one of the few meds we have that like they basically work while they're in your system, and once they've titrated out, they don't work. And it's like on off, and you can really kind of like hone that in to what's going to work the best. These, you have to take them every day. It takes a while for them to work. And if you skip days, then they may not work at all, like on any days. So if a patient is inclined to miss days of medications and and they're just not able to not do that, this may not be the drug for them. So not an option. And remember, with the Strattera, I talked about the 2D6. And remember, a lot of our meds affect 2D6. So, there's a lot of comorbidity between ADHD and other mental health conditions. These patients may be on fluoxetine, paroxetine, bupropion, which are all strong 2D6 inhibitors. In fact, many of our antidepressants are at least mild 2D6 inhibitors. Almost all of them affect 2D6 in some capacity. And remember, this medication is extremely sensitive to 2D6. So, whereas with a lot of meds, we may not be worried with a moderate or mild inhibitor, with this medication, even a moderate or mild inhibitor may substantially increase its levels in the blood. So, something to take into consideration there. If we're treating uh, other mental health conditions and there's some 2D6 effect and we're wondering, hey, what's going on, here? Well, it may be an interaction that we're seeing with the Strattera. All right. And then the prescribing guidelines say to have caution in those that have bipolar disorder because of risk of like manic, but like it doesn't affect serotonin at all. So like I don't really understand how that would happen, and I've never seen it. So I don't really have much concern about that at all. All right. So I talked about how atomoxetine is dosed based on weight. Um, so it's actually in two different ways based on weight. So if you have an individual that is 70 kilograms or below, which is a lot of people, a lot of adult. I mean, I'm 80 kilograms and I'm over 6 feet. So that's you could be a full sized adult and be 70 kilos or below quite easily. So the prescribing guidelines say 70 kilos or below, you dose zero point 0.5 milligrams per kilogram per day, with a target dose of 1.2 milligrams per kilogram per day and a max dose of 1.4 milligrams per kilogram per day, or a max total dose of 100 milligrams per day. Now, even though it does say this 70 kilogram thing, with adults, you're not, we don't do this weight based dosing with adults. So if you have an adult patient, you're going to dose it the same way you're going to dose it for those that are over 70 kilograms as kids. Okay. You're going to start with 40 milligrams, your target's 80 milligrams, and your max is 100 milligrams per day. And you can split this medication twice a day. So, if we're on 40 and we go up to 80, and like taking 80 all at once is making a patient like super nauseous, then you could do 40 twice a day and they may tolerate it better. Oftentimes when we do that, we can do the BID dosing for a while, and then like down the road we can switch that to single day dosing, and then they will not have the same tolerance issues. And that applies to a lot of the medications that we use. And I would say the issue that I see with this medication the most is kind of an upset stomach, nausea type of issue, as well as increased blood pressure and heart rate, which is something that patients not going to feel, but something that you would see on their vital signs. All right. And then in this study, this is kind of an older study. This is from 2003, where they compared atomoxetine to placebo and methylphenidate, and like we're looking at like weeks of treatment. 9 weeks out, of course, methylphenidate is the highest performer of the three, but atomoxetine still is outperforming placebo quite a bit. So they're using some sort of ADHD rating scale here, and it looks like everyone's starting at around a 37, and then the placebo, you only drop to like a 32. So like pretty mild improvement. And with the atomoxetine, it's going down to about a 20. So that's like a pretty big improvement. But with methylphenidate, we're down to like 13. So the higher the score, the worse the symptoms of ADHD. So this is a Connor's adult ADHD rating scale actually. So and let's see, what is this thing called? I don't know if I have the name of this study, but let's see. I think it's called Atomoxetine versus placebo, weeks 1 through 9. I don't have the name of it, but it's from Biology Psychiatry 2003. Um, and basically, you can see atomoxetine has a pretty good effect, not as good of effect of methylphenidate, but still outperforms placebo um, pretty well. All right, so that's atomoxetine. Um, I have, I'm sure I tried this on a guy for depression one time, which is something you could do. It's off label for depression, but like it's an NRI. Um, you, I've taken on patients that had been started on this by other providers. What I notice in my own practice is that like a lot of people are skittish about using stimulants, even in patients that are like of no known risk of substance abuse. They just don't want to take this risk on at all. And as we discussed in the previous episode, that risk is substantially lower than like a something like an opiate. Um, and the and it's I think it's way overblown. But like especially in the military, like people get really, I don't know, really skittish about it. And so they'll start patients on atomoxetine and bupropion, and it's just like it's not working. But like some patients it does, right? So I would inherit patients from other providers who were started on this. It worked, and they were happy with it, and I just continued it. But like I did get a lot of complaints of stomach upset. Like I'll remember in particular a couple patients that would tell me, um, "I need it, but I don't like it." Essentially, like I feel like I'm going to screw up majorly at work and it's going to be a huge problem for me, and this really helps, but I don't really like the way it makes me feel. And these are patients that you might want to consider switching to a stimulant if they've never tried one before. It's like, oh, you know, some of them some of them might be like, you know what, I'm happy with this. I don't want to mess with it. I don't want to, I'm the patient might be, I'm a little skittish of using a stimulant. I've heard things, and that's fine. You know, if you want to take your atomoxetine and you like it, and you tolerate the GI adverse effects you had from it, that's fine. You know that I have no problem with that. Go for it. If someone wants to use a non-stimulant instead of a stimulant, I am more than happy to do that for them. But like, I'm typically going to recommend a stimulant because they work better for for more patients. All right. So next, we're going to talk about Viloxazine ER. So it's actually it's there is a Viloxazine out there that is not prescribable anymore. So the generic name is Viloxazine ER, brand name Qelbree. Came out in 2021, so it's still under patent. This one, I've never used it. It's because it's a more recent med, and because it's harder to like with formularies to use meds like this, and it would probably be used more in the uh, child and adolescent population, which is not my population. I never have had a chance to use it or treat a patient who was on it. But I will still tell you what I know about it, which may be more than those that folks that use it. So that's why we're going over this. So its mechanism of action is actually, even though it is an NRI, are actually quite a bit different from atomoxetine. So if you're wondering, like, why would I use the more expensive cousin? Well, because it actually works quite differently. It's not very potent of an NRI, so it's way less effect on norepinephrine reuptake inhibition. It actually has some serotonergic effects that may be more prominent. So it's got some 5-HT2B antagonism, which actually could like maybe have some antidepressant effects. It's got 5-HT2C agonism, which could have antidepressant effects. It's got some 5-HT7 antagonism, which could have antidepressant effects, as well as pro-cognitive effects. That's something that we see with 5-HT2, 5-HT7, I believe, lorazepam like there's a couple of the antipsychotics, lorazine's one of them. Um, and So overall, it with the viloxazine, there we see increases in serotonin, norepinephrine, and dopamine in the prefrontal cortex. So where I kind of said before, hey, use with caution in patients who may have bipolar disorder, and I was like, hey, I don't really have a concern about this because it doesn't affect serotonin. We're talking about atomoxetine there. With viloxazine, there actually is effects on serotonin, so there may possibly be some risk there for bipolar patients. So if I had a bipolar patient that were treating um, for uh, for ADHD, and it's a lot of comorbidity, I'm perfectly fine using stimulants in these patients. In fact, I one of my few publications I wrote about actually monotherapy of stimulant use in bipolar patients to actually treat bipolar disorder. So I'm a little bit outside of the norm for that. But there, I wouldn't say that there's not any risk. There's some risk there. So if I did have a bipolar patient and I were avoiding stimulant and I were going non-stimulant, I would choose atomoxetine over viloxazine because I would prefer not to affect serotonin for sure. In fact, um, the stimulants themselves, methylphenidate and amphetamine, would have lower risk of manic causing mania than viloxazine because they don't affect serotonin either, right? I mean, a lot of people are kind of afraid of those using those, and it's like, oh, definitely make sure they have a mood stabilizer before you put the stimulant on there. I've, like I said, I've treated with stimulant monotherapy with a few patients with good results, and it did not induce mania. In fact, it decreased mania. But this one, viloxazine, because it affects serotonin, um, when we talked about, we haven't talked about bipolar yet, but like a lot of people in the past have used, how do we treat, maybe the mood stabilizer is controlling the mania, but it's not controlling the depressive symptoms. And so people will add antidepressants, and I generally would never do this, um, because it tends to destabilize the bipolar disorder and doesn't really treat the depression anyway. There's much better techniques, and we will talk about those when we talk about bipolar disorder. But this is one that, like, this would be like one of the last things. Like bupropion, I don't really have a problem with in bipolar disorder because it doesn't affect serotonin. But like this is one of the few ADHD treatments that actually does affect serotonin, and so I would probably be hesitant on this one. I mean, it's kind of complicated. 5-HT2B antagonism, 2C agonism, 7 antagonism. Does that increase risk of manic symptoms? It's kind of complicated. So it's not a serotonin reuptake inhibitor, which I would definitely be concerned about. And like a lot of our antipsychotics, of course, help with bipolar disorder, and they have similar effects on these serotonin receptors. So, thinking about it right now, I would probably have to analyze more deeply what these effects on serotonin receptors are before I would consider that. But like all in all, this is like not a med that I'm probably going to use. I mean, for many reasons. One being that it's expensive. Two being that this is like fourth line for ADHD. Also, it's a strong inhibitor of 1A2 and weak for 3A4, so it can cause drug interactions. On the plus side, it may work a little faster than atomoxetine, but like atomoxetine works reasonably quickly, and it's not like works as fast as a stimulant. Um, Another advantage over atomoxetine is, remember I said you can't like crush atomoxetine or sprinkle it. You can with this one, but you do have to take into consideration when if you crush it, you actually absorb it 10% less, which is kind of contra to what I would think. Normally, when you crush something, you would think you would absorb more of it, but with this medication, it's actually a 10% less absorption, so it would be less potent when crushed, but only a little bit. Um, and then a little bit of the backstory on Viloxazine. It was used in Europe actually since 1974 for depression, right? And remember I said, hey, these are NRIs. I mean, effects of serotonin, norepinephrine, dopamine. Hey, this could be used for an antidepressant. But back then, it wasn't the ER Viloxazine. It was just regular Viloxazine, and you had to dose it 3 times a day, which is, kind of onerous. And like, who's going to stick to that? People might be able to take things twice a day, but 3 times a day is a huge ask. Europe stopped using it back in 2002, unrelated to efficacy or safety. I'm not really clear why. Maybe it was because no one was using it, and because the 3 times a day dosing was just too much of a pain. The adverse effects, headaches, appetite suppression, and then apparently it may accentuate caffeine's effect. I'm not really sure how that works, but you might want to be cautious. I would be cautious with using caffeine in combination with ADHD treatments in general. Caffeine often can like help ADHD, though I really wouldn't say, hey, you should use caffeine to treat your ADHD. I talked a little bit about caffeine when I talked about non-medication options. As I mentioned with Viloxazine, the dosing, unlike Strattera, which was weight-based, this one is age-based, which is kind of interesting. Oftentimes, medications for kids are weight-based, milligrams per kilogram per day. This one is age-based. So in those 6 to 11 years of age, we start with 100 milligrams. We titrate by 100 milligrams weekly with a max dose of 400 milligrams a day. Those age 12 to 17, we can start with a higher dose of 200 milligrams and increase by a higher amount of 200 milligrams to the same max of 400 milligrams. And for those 18 and older, we basically also start with 200 milligrams, can increase by 200 milligrams, but we have a max dose of 600 milligrams a day. I don't know. I don't see myself using this for adults, but it's always good to have something else in your back pocket if other things aren't working. And maybe if other things are not working, you should be like, hey, what about Viloxazine? That's out there. Let's talk about some of the side effects with these medications. In children and adults, I don't know, for whatever reason, I have different lists. With kids, we've got abdominal pain, anorexia, so like decreased appetite, nausea, vomiting, fatigue, somnolence, mood swings. For adults, we've got increased blood pressure, constipation, dry mouth, nausea, vomiting, anorexia, dizziness, insomnia, decreased libido, urinary problems, and menstrual cramps. All right, so some of those things like decreased libido, menstrual cramps are not going to happen in kids, right? So urinary problems probably less likely. So maybe a little bit different, actually more adverse effects in adults. There are more things that could go wrong. And then I have to talk about the risk of hepatotoxicity as it pertains to atomoxetine in particular, because that's just something that's kind of out there. You'll just hear, oh, don't use this, it could hurt your liver or whatever. Well, let's dig deeper on that. First, let's talk about other meds that can cause hepatotoxicity. So valproic acid, when used in combination with other medications, 1 in 12,000. So 1 in 12,000 people will severely harm their liver. I feel like it's got to be more than that. 1 in 12,000, that's pretty rare. I've seen liver affected by valproic acid a few times, and I don't think I've seen 12,000 patients on valproic acid. I certainly haven't. I don't even know if I've seen 12,000 patients. So that seems a bit small to me, but that would be our biggest risk, would be valproic acid mixed with other stuff. Valproic acid by itself, I have a 1 in 50,000 risk. Felbamate, I think that's a not a medication I use. It's not commonly used. It's used for seizures. One in 25,000, but it's another medication that we commonly hear about with hepatotoxicity. Pimeline, a medication that no one uses anymore, as far as I'm aware. One in 100,000 risk. So that's kind of give you an idea of what the risk is with other common meds that have hepatotoxicity. Let's talk about atomoxetine. All right, so hepatic events associated with atomoxetine for ADHD. There's this big study, this is like 20 years ago, on 7,961 patients treated with atomoxetine. Like meta-analysis pooled all these people together. I mean, and this is the study that like basically revealed that there was a risk, but when you dig in on it, it's like, really? You kind of concluded that there was a risk based on this? So we have almost 8,000 patients. 41 of them had hepatobiliary events requiring analysis. So you're thinking, okay, 41 is not a small number out of 8,000, but like, what is an event? Well, most of them were mild increases in ALT and AST. That's not necessarily going to be a problem. A mild increase in AST and ALT, if it doesn't get worse, is really not much of a concern to me. There were 0 cases of liver failure. Okay, none. And remember, the valproic acid, 1 in 12,000 polytherapy valproic acid with other meds, 1 in 12,000 liver failure. So it happens. With that amoxicillin, it's never happened. No cases of liver failure. In the 4 years after it was approved by the FDA, so that'd be like 2002 to 2006, there were 3 cases of probable liver injury. So 3 cases total in 4 years. All right, that's not. I don't even think that's out of the 8,000. I think that's like just everyone who took it. That, there was a report that went to the FDA and said, "Hey, we got a case of liver failure in a patient who took Strattera. We think they might be connected." One of those cases, they re-challenged them. They like basically stopped it and then started it again, and they had a 6, and then they were fine. So basically, 1 out of the 3, it seems like, wasn't even a real case, and all 3 of them recovered. So it has happened. Not liver failure, liver injury. So something beyond a mild increase in ALT or AST. So you should check their liver labs, just in case it is I mean, that's an easy thing to do. But like, I wouldn't like not start it because of this, because it's pretty uncommon. In fact, a lot of our meds that we don't even think about have a similar risk. Okay, so you should stop it if they have jaundice or evidence of liver injury on their labs, certainly. And if it's to that degree, I probably would not re-challenge them. I mean, like, how vital is it that this patient take atomoxetine? Like, we can't give them something else. Um, and if somebody is a child Pew class A, liver impairment, there's no adjustments in doses. For B and C, which is still pretty significant, there are some suggestions for adjustment. So even in those with like that are having liver issues, it's not contraindicated to start atomoxetine. I probably wouldn't, but I mean, it's pretty uncommon that it causes the problem. And even in folks that have like I mean, child Pew class A is still impairment, like, that it's just mild impairment, and they're saying no dose change recommendations. So to me, you know keep it in the back of your mind that this is one of those ones that could affect the liver, but it's like super super uncommon. But like, um you don't want to ignore it. Okay, so I think that's good for today's episode. Got a little introductory to like the non-stimulants. I mean, you can hear my bias that like, it's, I mean, at least in the adult population that I frequently treat, I'm not like a huge proponent of these. um I think I don't treat a ton of patients anymore. So like, I think if you're treating more patients, you're probably more likely to run across folks that these would be appropriate for. So like, I'm not saying don't use these, they're crap. They're definitely not crap. I mean, the effect size, zero point 0.6 to zero point 0.7, that's nice. That's a nice effect size. So like, these are by no means uh not decent medications. These are good medications. These are actually some of our, like, comparatively, these are actually some of our best medications. It just so happens that they treat a disorder that we have other treatments for that are even better, right? So the great news about treating ADHD is we have a lot of really good options, right? I might poo-poo these non-stimulants, but like, hey, if the stimulant's not working out, we have a great alternative. Okay, these are actually, like, comparatively for mental health disorders, these are really good meds. And so like, if your stimulants are not working for you for whatever reason, this is a good option to try second, okay, or third. So I certainly don't want, like, I don't want to disparage these medications like, oh, I never use them, blah blah blah. It's like, oh, it's just because we have better things out there that typically work really well and patients don't have any issues with. But if your patient does have those issues, hey, our next line treatment is actually still better than pretty much everything else we have in our armamentarium for mental health symptoms. So like, um, I definitely would recommend the use of these medications in patients where they're indicated. And I wouldn't say, oh, these don't work that well. Oh, you can't use a stimulant. Well, we'll see if these work. No, these are actually pretty good. So just to put that kind of positive spin on there at the end, it's just that I, I think the reason why I'm a little bit biased is because it, with the people that I practiced with, I tend to see them go to these first, and that irritates me because I'm like, stop being afraid of the stimulants. Like, nobody wants to touch those, and so they go with the less effective treatment first. Don't go with the less effective treatment first unless you have a really darn good reason to. Go with the best of treatment first. If it doesn't work out, then go with these, and they're also a good option. But like I said, I'm biased because people will try these first in cases where they really shouldn't be. And I don't know. I'm not a fan of practicing like this, like, I forget the term for it, but like practicing medicine in a way to like cover your own butt, but like you're not really helping the patient as much as you should be. That irritates me, and I hate when people do it. Um, so don't be skittish. Do what you think is right, and go through the algorithm appropriately. And if these are the meds for the patient, hey, great. I think they're great meds. So I want to thank you for joining me today. I hope you enjoyed learning about atomoxetine and viloxazine. And we are going to talk about some other FDA approved non-stimulants next time, along with the off-label treatments. And I hope you will join me then, and I will see you next time.